Okay, well, welcome again to one of these COVID live sessions. Today, I'm going to go through in really excruciatingly boring, potentially detail about the R, what it is, how it works, and then to use that information so you can sort of see maybe how lots of health professionals see it, what will happen over the next 4 weeks, 5 weeks, 6 weeks, and what we can change and what we can't change, and what we should do, and also what is the strategy, you know, what is going on. And as ever, you can ask questions on the stream here or also on Twitter, and I'll try and pick them up as I go on. Okay, so let's kick off, shall we? Let's just make this a bit bigger. And what I might just do is make this a little bit smaller so that fits into the screen a little bit better and doesn't overlap my face too much. Okay, so first of all, what is the R? Now I know this is a very boring question, but I think it's really important to sort of just drill down into the basics, okay? So here we are with one infected person, infects 2 people. This time, this arrow here, is called the generation time, and if one person affects 2 people, that's an R of 2. Maybe not have that color, maybe use orange. And equally, if the R rate is, if 2 people only infect 1 person, so 1 person only infects half a person, that R rate is 0.5. And in this scenario, over 6 days, you'll have twice as many cases after 6 days as you started with, new cases. And in this scenario, you'll have half as many cases as new cases as you started with the 6 days before, which is roughly the time for COVID. So it's really important that the R rate is a measure sort of the speed, but also direction. So if it's above 1, you're growing, you're going forward. If it's below 1, you're falling and you're going backwards. And then it's an exponential sort of figure, so 2 is twice as much, 1.5 would be 50% more, and then equally this is halving, so this is it's dropping by 50% every 6 days. So it's direction and speed, and I think that's really important, and we'll come back to that. So let's go down here a little bit more. So this is just to give you an idea of some other infectious diseases. So there's a whole bunch of diseases here. You've got hepatitis C with an R of 2, Ebola with an R of 2. So remember, this is different from the mortality, because obviously Ebola had a much higher mortality. SARS had a very high mortality, and also R of 4. And interestingly, mumps and measles, so ones that we vaccinate for, very, very infectious. And measles is sort of the classic one with an R of 18. Can you imagine? An R of 18. So here's COVID, SARS-CoV-2 or COVID-19, the disease, and we think the R unmitigated in natural life is between 2 and 3, although there are some higher estimates and there are some slightly lower estimates. Just for comparison, here's flu with an with an R rate of 1.3, and that's sort of the average, but some years that can go up and some years that can go down, and depends on the strain of the flu. So that's a sort of overview then of lots of different diseases, where SARS fits into that. So more infectious than lots of respiratory diseases, not as infectious as some of the well-known diseases that you know already. So somewhere in between. But crucially, more infectious than flu. And that's important too. Come back to that. Now, the other thing is, and this is again really irritating maybe, is how does SARS-CoV-2 actually spread from one person to another person? Now, I've drawn this diagram. We all know this by now, but I think it's just really useful to look at it, because it talks about how we what can we do that will change that R value. So we've got modifiers of the R. So the first thing is, well, how are things spread? So you've got aerosol droplet spread. So you cough over here, your aerosols go in the air and they infect another person. We can do a lot here to mitigate that, and we'll come back to that. Also, there's a difference between aerosols, which hang around in the air, and droplets, which hang around in the air for a very short amount of time on distance, and then fall on the floor. And when they fall on the floor, and you touch them, and then you touch your own face or your nose, and you infect yourself that way, that's called fomite spread, but it just means through surfaces. There's also feces spread, which we never talk about, and we won't talk about that much, but it's just so you know it is in there. And in this situation, you've got one person using all these different routes, infecting 3 people. So that's R of 3, just to come back. Now let's look at what we can do to modify the R. So there's some really good videos here from the beginning of the pandemic. So here's a video from YouTube, actually. And it's all about how your masks and your coughing change how much droplets and aerosols are put out into the air. So just to orientate you, then you've got no mask, cloth mask, 2-layer cloth mask, so sort of more, and a surgical mask, and that's the differentiation of the different groups. And you've got a high-speed camera taking pictures of different activities, and this is just counting. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You see, with each enunciation, when you're talking, you make droplets. With one mask, it's mitigated. With a 2-layer mask, and with a surgical mask, nearly no droplets are spread, despite talking all the way through it. So in all these pictures, the same person is counting. And you can see a little bit of escape from here, from the droplet. Is it projecting? Yeah, more or less. Maybe just zoom in a bit more. So there's 2 functions here. You can see making the droplets, but also the distance that it goes. So there are 2 modifiers of how the R can be reduced. What did this one? This is coughing. So you cough here, very fast spread of droplets. With single mask, still get some droplet escape. 2-layer mask, less droplet escape. Surgical mask, no droplet escape. So you can see instantly that if you modify how the risk of transmission occurs, you can modify the R. Sneezing is going to be the big one. So let's have a look at this. And again, this might be really boring, but I think the basics are really key, because none of them have really changed. So look at this: high velocity, loads of droplets produced, and continuing to produce, and loads of aerosols. Some little bit of droplet spread here, much less here again. And even if you sneeze through a surgical mask, which I can contest, not many droplets escape. So therefore, 2 ways to modify the R when you're talking about aerosol and droplet spread are distancing and masks. Now let's talk about hand washing, and this is another great video that I helped contribute to. Let's watch this, and what we try to do here is visualize the actual virus, to sort of re-emphasize the importance of how things are spread.
The following reconstructions of everyday environments show why washing hands regularly, wearing a face covering, and keeping at least 2
again, it's
meters
just kind of
apart
reinforcing
is
the basics.
vital in controlling the spread.
So this lady's just come in from outside, touched the phone, touched her face, and touching phone and face. So this is the virus. So she's been outside. She had some virus on her hand. It's now touched her face. It's now touched the mug on the table. It's now touched the phone. And it's now touched the doorknob.
Washing your hands with soap and
Whereas if you wash your hands, and SARS-CoV-2 is a very weedy virus, so alcohol and soap disrupt the virus very readily, and washing hands works very well, 20 seconds. Again, none of these have changed.
In tiny droplets coming out of your nose and mouth.
So this is a good visualization of day-to-day aerosol spread.
Reduces the spread of droplets.
So as we saw, if you wear a mask, even when counting or talking, so this man's wearing a mask, and his sort of normal breathing and talking aren't leaking any aerosols, and this lady is not, and you can see there's some aerosol leaks from her. These are just visualizations, but you kind of get the picture, and you get some aerosol spread inside.
Can land on other people or on surfaces.
This is quite, this is what we mean about fomite spread. So the droplets land on surfaces, infect those surfaces, and they can be touched and then be infected by others.
Is most likely to happen when you are less than 2 meters apart.
So again, a good illustration. There's some talking and aerosol production here, but there's a big space difference between the 2. So again, the R is reduced because you can't physically reach that other person. Not that you can.
If there is no ventilation. So when you are with people not from your household.
So this is a really good example. So again, if we talk about droplet and aerosol spread, and unfortunately I haven't got a video for this, but if you're outside of here and there's a big gap between the 2 of you, then
at least 2 meters apart.
You need to keep 2 meters apart.
The risk of spreading the virus through smaller droplets is much less outdoors, where there is more ventilation. Wash your hands, cover your face, make space.
So I think I'll stop it there. But one of the key things that we talk about, and we haven't really mentioned much in this pandemic, is if you are making other modifications to the R, one of the big things that will drive is ventilation, which reduces the amount of droplets and aerosols hanging around in the air. So you've got hand washing, you've got masks, and they are still, the mainstay of treatment for modifying the R rate. Now feces, yeah, I won't go too much into that. But one thing I will say is you should put the toilet seat down when you flush, because there is some case reports that this can also aerosolize, which is gross. So we won't talk about that too much. Now, the other modifiers of the R, which is also really important, the first is contacts. And that makes sense, right? If you don't physically see these three people, you aren't going to infect them, regardless of what other methodology that you take. So if we reduce the number of contacts, reduce the number of households that we come into contact to regularly and spend a lot of time with, working from home, avoiding public transport at key times, and also when you're on those public transport and you can't avoid it, taking these precautions to avoid making too much contact that you otherwise wouldn't have made. It's just being much more conscious of that. And then the last thing is susceptibility. So if 3 of these people have been infected already, then you can't transmit the virus. And that's also going to modify the R, because the number of people that can actually be infected. And that's what we start to talk about. We talk about herd immunity. So there's a number of people total that you actually reach, which are sort of contacts, but also the people in a closed location, like a country or an island. And then how many of those people cannot catch the virus and cannot spread it onto other people. So that what is the immunity? And that is the true definition of immunity. So that's how you modify the R, and that's where we've got to. In the springtime, the R was about 2 to 3, and currently it's sitting about 1.3 to 1.5. And there's been a lot of speculation about why the R is different, but the most likely answer is, and most obvious answer is we are all taking these precautions quite consistently. Everybody's aware of the virus, mask wearing is fairly ubiquitous, we are washing hands, social distancing. You can look at some of the mobility data from mobile phones, and you can see that about 30% of people are still working at home. The reduction in in shops and restaurants is down about 30% as well. So there's a big interest here. And the other point of ventilation, some countries, especially Nordic countries, increased their outdoor park time by 300-400% in the summertime. And we only managed about 50%, and now it's gone back down to baseline because the weather has changed. So ventilation is really, really key. And in the winter, that's going to be really hard with the weather. But that's one of the main things, is go outside and meet people is so much safer. Good. So let's keep going. So this is just an illustration then of what happens at different R's, okay? So this is a logarithmic scale. So you've got 1, 10, 100, 1,000, 10,000, 100,000, a million, 10 million, and 100 million. And I've only really, drawn this out to sort of illustrate what happens with exponential growth when the R is different, but also to illustrate that the R drives you in 2 directions, okay? It can drive you up into the millions and hundreds of millions of cases. It can drive you down into the thousands and hundreds of cases. And that is a really key point when we talk about what the R is doing, because the main thing really is the direction. Is it above 1? Or is it below 1? And if it's at 1, which is this middle line here, you can see that it just stays the same. So this is a hypothetical scenario where we started at 10,000 cases, which is probably the case about 4 or 5 weeks ago in the UK. And if the R sit at 3, which is this blue, maybe I should just draw it on here. So you've got R of 3 up here, which is just an extreme example, really. But you can see, and this is weeks along the bottom, which is I've sort of muffled the generation time to be 7 days just to make the numbers easier, but it's about 6 days, so slightly shorter than this. So if you start with 10,000 cases, by, by 3 weeks, you've passed 10,000 cases. So it takes you 3 weeks to get there if your R is 3. And by, about 5 weeks, you're at 100,000 cases, and by about 7 weeks, you've passed 1 million cases. So this is the trajectory, and over 9 weeks you get somewhere into the region of 65 million cases, which is the entire population. But the R obviously will start to dip as you run out of people to infect. So that's what happens at the other end. But in none of the scenarios we've got close to that yet. So, that's just to make you aware. Now here's an R of 2, and you can see that the slope is in a similar direction, quite exponential growth. But instead of taking only 3 weeks. It takes you 4 weeks to pass 10,000, and to reach 100,000 it takes you 7.5 weeks. And then we've got an R of 1.1, which is actually a lot lower than we think it is now. It's about 1.3 or 1.6. But you can see over a period of time that cases do continue to increase. You probably get to about 30,000 cases here pretty quickly. And the other crucial thing, if the R is 1 or about 1, then your number of cases every day just stays the same. So you get 10,000 cases every single day. It doesn't change. And similarly, well, completely opposite. If the R drops below 1, then you see that cases rapidly go in the other direction. So the most extreme example here, so this dark blue line, let's just change this to navy again, is an R of 0.5. And you can see you go from 10,000 cases to 1,000 cases in 2 weeks. And similarly, if your R is so that's 0.3, and if your R is 0.5, which is this green line, it takes you about 4.5 weeks to get below 1,000 cases. Now the reason I've illustrated it like this is that the R in and of itself is not that useful. What is useful is knowing the direction that you're going, but also what are the hard numbers, right? What are the case numbers every day? Because actually we only have a finite number of resources to cope with in hospitals. We only have a finite number of what we might accept as an acceptable level of death for any respiratory virus before we start taking measures to control it. And we also know that there's a finite threshold where functioning track and trace will work. And in this hypothetical example, I've made that threshold 1,000 cases a day. And I'm not sure if anybody does know what the threshold is for track and trace for it to work properly. It's clearly not working properly at the moment. But for each positive contact, you have to probably contact between 20 to 30 of their contacts. So 1,000 cases a day, you're still doing 20,000, 30,000 contact tracing, which is still a really big ask. So it's not unreasonable. But you can see that in this scenario here, starting at 10,000 cases, if you drop the R to 0.3, which is probably not realistic, even the spring lockdown was about 0.6, it takes you about 2 weeks to get to that level where track and trace can take over. That's like a super circuit breaker. 0.5, which is probably what a circuit breaker kind of thing, spring lockdown would look like, takes you about 4.5 weeks to get there. But you can also see that, keeping the R around 1, 1.1, 0.9 never gets you close. So it doesn't do anything. It doesn't change the parameters of the problem. And even an R of 0.9, after 9 weeks, you're nowhere near. Okay, but that's important because if we look at starting at a slightly different level, again, so the R in and of itself is not that important as actually what the case numbers are doing and what the direction of travel is. So this is exactly the same scenario. All the R numbers are the same. This is R of 3, this is an R of 2, this is an R of 0.3. But what we've done here, although I don't know why it's added so many extra things at the bottom, let me just illustrate it so we make sure that's clear. R of 3. But all we've done is changed our starting point. So here we're starting at 2,000 cases a day rather than 10,000 cases a day. Every other parameter is the same. The functioning track and trace threshold is kept at 1,000. The R numbers are all the same, so the restrictions or lack of are exactly the same. And we can see that an R of 0.3, instead of taking 3 weeks as it took us up here, it takes 1 week to get to that level where track and trace can take over. Similarly, if the R is 0.5, it takes us just about 2 weeks, whereas here it took us nearly 4.5 weeks. And actually, if the R is 0.9, you do actually reach that threshold eventually. You get to sort of less than 1,000 in 7 weeks. So this is an argument of why early intervention works much better than late intervention, because your starting point is so much higher. So it's going to take you much longer with the same restrictions to get back to where you can start to suppress the virus and reopen the economy with successful measures. And this is really important because the longer we wait, we're just going up and up and up and up on this scale, and it'll take longer and longer and longer to come back down again. And that is the biggest problem we had in March, and that seems to be the problem that we're having now. So let's look at deaths, and these are hypothetical scenarios based just to illustrate what happens. So these are a range of deaths over time, and again this is a logarithmic scale. Let me just zoom in a bit more so you can see it a bit better. So down the side here you've got 1, 10, 100 deaths, 1,000 deaths, 10,000 deaths, 100,000 deaths, 1 million deaths. And if you take an R and you have a starting point, this is just to follow on our example, you can see over time that the R increases 0.3 to 3, but the kind of point I'm trying to make here is, so this is your R of 3, which you'd expect, very high takeoff point, exponential increase in deaths, 1,000, 10,000, and it keeps going. R of 2. But this is the R, remember this is the R of 1.1, okay? So we didn't think much of that. But actually, if you look at the trajectory here, you're still rising. The number of deaths just goes up and up and up every single day. And actually, even more importantly, if the R is 1, so you know, somewhere that we're trying to aim for, R of 1, you still get an increasing number of deaths, which makes sense because you have the same number of cases every day, so you have the same number of deaths every day, but they pile up. 100, 200, 300, 400, 500, 600, 700, and so on and so forth. So even if we did nothing and we kept the R at 1, that is not success because we still have, and the higher you start this off is that you have the same number of deaths. So I've started this as an arbitrary number of 90 deaths a day, and over 9 weeks that increases and it accumulates to 540. But say you started somewhere up here where you're having 250 deaths a day like we're having right now. If we got the R to 1 today, we would still have 250 deaths every single day. I've got some kids crying back there. 250, 500, 750, 1000, 1250, 1500, and so on and so on. So an R of 1 or above is not success, it is failure, okay? And that's really important to remember because ultimately we're talking about lives, but there's also a number of finite resources, hospitals, the death number that will actually accept, what is a normal excess death for the winter, etc. Now, lastly, I just wanted to say there's some ways that the death rate is modified. So the first thing is when we do something, okay? So this is just a hypothetical scenario, again, kind of illustrating what I was saying before. So along this top line is an R of 2, because I haven't wanted to make the numbers too big. Let's make the colours match. So again, the top line now is an R of 2. You can see deaths keep rising. Now at some point, if you intervene and you modify the R so it drops to 0.6, which is essentially exactly what we did in the spring, depending on where you modify it is the number of deaths that you'll finally end up with. So if you modify it here, which is week 5, and just change that to an orangey colour. So at week 5 in this simulation, if you dropped it to 0.6 here, you end up with a number of deaths, I don't know, it's probably in the region of sort of 5,000. But if you do the same, so you're doing the same intervention, right? You're locking down schools and shops. Or the only thing that changes is how early you act. Okay, it doesn't really matter. You know, there's no other parameter changes. So here, if you modify it, say to 0.6, and then you finish up with a death level of 900. So in 2 weeks, we've gone from 5,000 deaths to 900 deaths. That's probably actually closer to 7,000 anyway. And just as a final example, if you modify, you see this inflection point here where you are going up, but then we modify to 0.6, you end up with a sort of deaths of around 105. And if you look around the world, you can quite accurately plot these graphs. You know, this would be Vietnam, for example, which took very early action. And unfortunately, this scenario up here with much late action, 5, 6, 7 weeks after our first case, is us. And the difference in magnitude of deaths is massive. And the last thing to talk about how we're modifying deaths, and this is just a graph to kind of show what happens if healthcare gets overwhelmed. So if I just bring this back to you like this. Okay, so again, what I've done here is I've just done exactly the same scenario, so I'll just keep redrawing it so we can stay orientated. This is an R of 3, here's an R of 2. Now you can see that the death rate increases at different points in the R curve. And what happens here is there's a certain level, and in this simulation it's completely arbitrary. So when deaths go over 1,000, the IFR here in the simulation goes from 0.1. Change it, to, I think I made it 1, to an IFR of 2. Oh, hold on, let's change that to... Anyway, IFR increases, IFR. So at each threshold where your hospital services are overwhelmed and your beds are overwhelmed, your mortality keeps increasing because you have less resources to deal with the sick cases, so that the mortality rises and continues to rise. So actually you get an acceleration, which is the other thing that's really important to remember. If at any point you lose control of resources, your mortality will increase beyond that, beyond the natural IFR of the virus. So you can modify not only the R, but also the fatality rate. Whereas similarly, if you don't get any modifications, you get the same number of deaths, but it increases the number of deaths where you overwhelm the healthcare service. Good. Okay, so now let's look at where we are right now. Oh, before we do that, so the next thing to say is when we're looking at any of these numbers, we have to take into account the fact that we know about the virus, we know what happens to it, we know that from exposure to symptoms is 5 to 7 days, and that's your incubation time. And then we also know, just zoom out a bit here, that your hospitalizations and deaths, so symptoms to hospitalization is around 7 days, and your symptoms to death is 18.5 days. So this whole process from when you're exposed to when you die is roughly 4 weeks. Again, these are average numbers, but we're kind of trying to make sense of the numbers with translating it back to what's really happening in reality. So if you die here, you caught the virus more or less a month ago. Now, when you caught the virus is the most important day, because obviously that's what the R is doing at that particular time when you were exposed. So when we modify the R today, we're talking about modifying deaths in 4 weeks' time. And what happens in between has already happened. All the people that will die for the next 4 weeks have already been exposed. Just remember that, because it means that we can do nothing about the next 4 weeks in terms of deaths. In terms of hospitalizations and cases, you can see hospitalizations here will start to change about 1 to 2 weeks after our intervention. But everything else is baked in for the next 3 to 4 weeks, which means that we can sort of fairly accurately see what's going to happen, but also enforces the fact that we must take action now if we want to make a significant change, and we'll come back to that. Okay, so here is reality then. This is the UK. This is the UK total number of cases. So this UK number of deaths actually. So this is the spring wave, and here's our winter wave, and roughly we think the R was 2 to 3, and you can see that big increase in March. The lockdown came in 24th of March here, and a month later, remember that, we start to see the decline in cases. I'm just going to draw that on because that's really important. So the peak here is April 10th. Mobility data in the UK started seeing a decline from the March the 14th to full lockdown on March the 24th. And so this gap is when mobility, which is a good measure of what people were actually doing, started dropping, and then the case numbers here dropped as well. So exposure, you can't die of a virus that you're not exposed to. Okay, so if you reduce the mobility, you reduce interactions, you bring down the R with all those modifiers that we talk about, and then you reduce it all the way back. And in the summer, the R was very low, transmission was low, there was good distancing, many people continued to stay at home, work from home, and also people spend a lot more time outside, ventilation. But now the R is rising again, and we think it was about 1.5, 1.6 at the early start of this, and then we're seeing a slower curve. But you can see that this curve is not like this. And the modifiers of the R we talked about are the ones that we're still doing. Now there's this survey, so the issue with case numbers is it's very reliant on capturing the actual number of cases that you can see. Now there's lots of different reasons why you are not going to be able to see the number of cases, mostly around a failed track and trace system. You're not going to fully track the cases as you would otherwise, so you can't follow up on everyone. But what we also do is we survey and make estimates of what the number of cases, the true number of cases, total number of infections are in the country. And this is the ONS survey, and they regularly test a whole bunch of households. I think there's about 150,000 members in this survey now. And then from this data, they estimate there was about 35,000 cases a day from the 16th of October, so last week, which works out about 400 deaths a day. And if we look back at what the death data is, so currently we're sitting at 224 deaths a day. So remember, so we have to look back at what was happening exposure-wise a month ago. And from the same ONS study, they estimated about 17,000 cases a day, which brings an infection fatality ratio of about 1%, which is more or less exactly what it was in lots of the serology studies and what is thought to be pretty much throughout this entire pandemic, between 0.5 and 1. Slightly higher in the UK, probably because of older population, slightly higher burden of comorbidities. About 31% of the population are at risk of severe disease from the global disease burden study. So that's just a sort of illustration then of what we can expect to happen in the future. So if we have 35,000 cases today, in a month's time, from the 16th of October, this number is probably now at 50,000, we'll expect about 400 deaths every single day from the middle of November. And that we can't really do much about that, unfortunately. And we can sort of plug all that data in to those same graphs. So this is essentially a simulation based on those same graphs that we just looked at, but with the actual data. So this is deaths per day. We're starting at around where we are, basing on the 35,000 cases from a month ago. So in a month's time, if we see the same ratio of deaths, 1%, we'll start off here at 400 deaths per day. Now, what the R does over the next from that period of time onwards is dependent on our behaviour. And I put a selection of what I think are realistic R's here. So we started at 1.6. We think we're down to about 1.3. The actual target should be to get as low as possible, right? It should be to do 0.5. And I'll come back to this, because otherwise I'm not really sure what the point of all of this is. But we'll come back to that. So if the R stays at 1.6, then this is this is Christmas time over here. So we're passing 100,000 deaths by Christmas. Now these are pretty stark numbers, but this is based on all the data that we have at the moment. 1% IFR. That's looking at the ONS study and the actual deaths we have right now. If we keep the R at 1.3 where it is now, we'll have 78,400 deaths by the beginning of next year. So another sort of 50 to 60,000 deaths. And there's a selection of deaths here. But crucially, if you keep the R at 1, which is not success, from the starting point we have now, we'll still have 22,000 deaths by January. Now, whether or not you think that's acceptable, I don't know. But my point really is that the deaths will continue to rise at an R of 1. And this is the kind of thing that we need to think about when we're describing R at all. And then the other thing to look at is, there are thresholds here that will modify. Remember I showed you that the IFR changes as you pass certain thresholds of resources, of what's being overwhelmed. So these are our number of cases. So this is a number of hospitalizations every day. So this is slightly more difficult to work out. But again, if you go back to the ONS study, so we know that when you have a case, if you need to go back about 2 weeks to exposure, because exposure to symptoms is a week, and then symptoms to hospitalization is another week. So we're looking back in time 2 weeks. So if we see that we had 659 hospital admissions in the week just gone, well, what was happening 2 weeks ago? We had 27,900 cases a day. Again, that's from the ONS study, which is a sort of more accurate of trying to gauge what the actual infection level is in the country. Then that's a sort of 2.4% hospitalization rate, which makes sense, and that fits with what we know about the data. And then, so we can kind of guess, as the ONS and the cases rise, what the stress will be on hospitals, and we'll come back to that. And the other point is, this is the same graph, but just looking at patients who are admitted to ITU for ventilation with COVID, and currently we're looking at an increase of an average of about 18 a day. So if you go back in time and you look at that compared to the number of cases, you get a sort of mechanical ventilation rate or ICU admission rate of 0.06%. So that also gives us an idea of how many patients will need a ventilator every single day over the next 2, 3, 4, 5 weeks. And again, we can't modify these numbers for 2 weeks. Beyond that, we can start to modify it. But between now and 2 weeks, we can do nothing. This is baked in already. So this is just some graphs just projecting the number of cases and what will happen between now and essentially Christmas time. And then we can look at what will happen to hospitals and ventilated beds. So this is the estimated number of infections by Christmas. I've not made it logarithmic, just to make the numbers a bit easier to look at. So here's 10 million, 20 million, 30 million, 40 million. I've put in this green line because if the project is herd immunity, and we'll come back to this, if the project is herd immunity and we think about a maximum 13% of the population have been infected, which is roughly about 6 to 12 million, about 12 million people, then we probably need another 50 to 60% to get to a herd immunity threshold of about 80% overall. So that's about 40 million more people. So the threshold is here. Now this is an R of 1.6, so we're not doing that. We're doing a 1.3 at the moment. So we won't reach the herd immunity threshold anytime soon. You know, for weeks and weeks, all the way to Christmas, we're not going to reach it. So nothing will change. And that's kind of my first point, really. Now let's look at hospital admissions. So this is a pretty scary graph. So I'm just going to ignore the 1.6 scenario and hope we never go that way. But this is, now let's just draw it on so I don't lose track of where we are. So here is an R of 1.3, which is what we're doing right now. Okay, so this is live in terms of the R. This is the number of beds in the UK. That's the total number of acute care beds, so not including maternity or paediatric or mental health beds or day beds. There's 100,000 acute care beds. So this is the threshold for when we actually physically run out of beds in the hospital. And on our current trajectory, looking if the R stays at 1.3, then and based on that data that we've already got, we'll hit 100,000 beds admitted by the first week of December. That's like 5 weeks away. If we manage to get the R down to 1.1 or 1, we'll even an R of 1, by the time we get to Christmas, will still, half the beds in the entire country will be filled with COVID patients. So that means we can't do anything else. And I don't know what the critical threshold is, but we don't have a lot of capacity in the first place in the UK health system, to cope with a big influx of additional patients. And the only way that we'll manage to cope with any of this is if we have to end up closing more services. And just for argument's sake, if we have a circuit breaker and we keep the R as low as we can, it may go up again if we start opening things up in a few weeks, but we'll end up with a vastly lower number of cases and we'll stay well within the threshold for what we can physically do. And this is the key point. There's only so much we can physically do. So where are we going? Because there is a cliff edge coming and we can't avoid that. We can't change that. We can't make more staff, can't build more hospitals, can't add more beds. So where is this going to happen? So just to reiterate, if the R stays at 1.3, which is a good outcome currently for us, we run out of hospital beds in England by the beginning of December. And that's probably a very similar case between Wales and Scotland, but obviously they've now taken different action. We haven't taken the same action. Wales is now having a firebreaker. You'd hope that would drop the R to about 0.5. So they will go on a very different trajectory. But we are carrying on this one. And the last thing to say here is to look at our ICU beds, which are even more short in supply. So there's about 4,000 intensive care beds. So again, I'm just going to ignore this R of 1.6 because it's scary. So let's just look at what happens if we just continue on this trajectory as we are now. So this is your R of 1.3, which is where we are now. And you can, so I've written two things here. I've written usual capacity, which I was saying is about 20% or so of the beds that we have, which is about 1,000 beds. We're very close to breaching that number already. So there's 850 patients right now in mechanical ventilated beds. Sorry, there will be as of the beginning of next week, end of next week. And then by the week after, by the end of the week after, we'll be over that number. So once you start cannibalizing usual capacity, you have to get those beds from somewhere else. And that means cancelling operations, that means cancelling cancer operations, heart operations, that means redeploying care and prioritising. Because we only have so many beds and we don't have that many staff. The Nightingales will not save us. We don't have sufficient staff to open 40,000 or whatever it is ICU beds, regardless of ventilators. So I've also done this threshold here, which is the total normal ICU beds. So that's 4,000. And in the R is 1.6 scenario, we would breach all of the ITU beds in the country, which we did in spring as well, by week 7. So that's in 27th of November. And even on the R of 1.3, by the middle of December, we breach all of the ITU beds anyway, again. And there's a myriad of scenarios here. Again, I'll just draw your attention to if an R of 1, we're still going to have about half the ITU beds full of COVID patients, which completely obliterates our capacity to do anything else by Christmas. So these are the numbers, and again, there's not very much else information-wise. There's no other fog of data that's going to interrupt these processes, and this is a process that's been going on for weeks. And it's kind of having a conversation of this is a threat. This is obviously a threat. We're seeing it's a threat. We know it's a threat. I saw it personally firsthand in March that it's a threat. It's a very significant threat. Never seen anything like it in my whole life. And yet here we are again arguing about this fact. And the numbers are the numbers. It's actually a relatively simple process to work it out. You can sit down with a calculator in Excel. I did this morning. It didn't take very long. And there's a finite capacity of what we can do. And beyond that, deaths will increase. I mean, if you need a ventilated bed and you're in COVID, you don't get it, you die. That's as simple as that. So here's a summary then of all of that. But the key points, I think, is that the R remains at 1. Cumulative deaths, hospitalizations, mechanical ventilation beds will still rise. So even if we get the R down to 1, it's not enough. The R must be below 1 to reverse the process, to make sure that we don't have so many cases coming down the line, that we can do cancer care and operations down the line. And we will breach resources very soon. You're seeing that we're already starting to breach in some places ITU resources, and the way we're coping so far is by cancelling operations, as we did in the spring. And if we start to having to breach hospital beds, then we'll have to start cancelling other care, urgent care. Minor operations will get cancelled if anaesthetists get deployed. And then when you start having to redeploy other doctors, I was a cardiologist and redeployed to intensive care, all of the heart services get cancelled as well. And we've already got a massive backlog. So really what we need to be operating is not even at usual capacity in the NHS. We need to be operating at negative capacity, which means we need more capacity to catch up. And we're doing the opposite, is that we're taking up that capacity once more and not providing the resources to catch up in significant numbers that we otherwise would need to, and we won't be able to A, catch up on the backlog, or B, cope with the cases coming down the line. And this is, these are just the numbers. There's nothing interesting or mysterious about this. Which begs me to ask the final question of this sort of session. What is the strategy here? Okay, what is the plan? Currently, in England, we are doing local lockdowns, which we know from the R are not having a significant effect. We're not seeing the R below 1 anywhere, which means cases are only going to continue to rise. The trajectory might change, the speed might change, the destination does not change. And the destination is a very dangerous cliff edge, which will be very dangerous for many people in this country. So what is the strategy? Is the strategy to save lives? If the strategy is to save lives, then it is clearly failing, because every time that we leave the R above 1, you get exponential increase in cases, and then deaths, and then hospitalization, resources, and more deaths. Is the strategy herd immunity by the back door? So we talked about in the springtime, very early on, a lot of chat about flattening the curve and building some immunity into the system. The curve is flat, but it's still rising, and it is still going to breach that threshold. I think I did the calculations. If we wanted to produce herd immunity in March and affect sort of 60 million people in the population, it would take about 15 years. That's how flat the curve. So we're still going too fast. Okay, and it's also very likely to fail because we're going to breach the resources before we get to herd immunity. And you saw that graph. If we're looking at an R of 1.6, we're going to breach hospitalizations and breach death. We could keep the R at, say, 1 for a prolonged period of time, but even that will take up half the hospital beds and mechanical ventilator beds in the country by Christmas time, which will be the peak of the pandemic, and that's going to ruin a lot of people's Christmases, mine included. So it's very likely to fail. Then we'll end up having to try to save lives, having lost hundreds of thousands of lives, and we're going to fail again. So again, what is the strategy here? Because it doesn't make sense. And the last thing I'll finish with is, this is a really good illustration of the R. We are currently parked on a cliff edge. This is us. This is the cliff edge of many, many deaths, hospitalizations, resources being used up. In this scenario, what is the most important factor? Is it your speed or is it your direction? It's clearly your direction. If you drive forward, you go off the cliff. If you reverse the car, you go backwards. If you reverse the car slowly or fast, it doesn't matter. If you forward the car slowly or faster, okay, we might have a time to worry about that cliff edge, but we do nothing to change the outcome. We still go over it. And that is where we are right now. That is why having an R above 1 is completely meaningless. It doesn't work. It means the lockdown is not working. And all you're doing is prolonging economic harm and all the other harms of these lockdowns in Manchester and Liverpool and all these places without achieving what we need to achieve, which is a reduction in cases, reversing cases. Then we can manage holistically the non-COVID care, the mental health, the cancer and everything else. So what is an avoidable and preventable disease, as we talked about at the beginning, and going back to normal life, unfortunately, there's no realistic way back. So when we talk about the R as success in terms of 1.1, 1.2, that's not success. That's just delaying the cliff edge. And we want to reverse it and buy us some more time to get track and trace so we don't go over the cliff again. Get us back on the road, as it were, back below that 1,000 cases. And the longer we wait to do that, the harder and more economic pain it will be to get there. But the other option is that we don't do that and we end up in a situation where we try to do that again further down the line. And currently they're talking about reevaluating in mid-November, when if we look at the cases before, then basically we're looking at the Christmas scenario, an unmitigated Christmas scenario of an R at 1.3. And we look at deaths in that situation, and we find ourselves, where's Christmas time? Here. So over 100,000 dead. So if we waited till November to do anything, we don't change exposure till Christmas. So basically we do nothing until Christmas time. We start to see an effect, but by that time 100,000 have died. And even if at that time we don't modify it sufficiently to bring the R down below, we're still rising with a very high number of cases. So this is where we are. This is why the circuit breaker idea makes any sense. We'll probably see that in the next couple of weeks. And these projections are just Google and a napkin essentially, but will be the case. Any questions? Someone said we need you to do the daily briefing. That's not a good idea. Did you wear a mask for the 2017-18 flu season? Yes, I did. I wore it all the time in the hospital because we looked after lots of patients, and very careful about washing hands on the tube and back, etc. And we actually had full FFP masks in the hospitals at that time. Didn't wear a mask in the shops, etc. But actually lots of countries that have been through these pandemics do wear masks all the time in respiratory seasons, and maybe that is something that we should consider, considering the number of flu deaths. But historically the number of flu deaths have been about 17,000-18,000 a year. We're currently at 60,000 with COVID, so we know the IFR is much higher. We also know the infectious rate is much higher, so the rationale for masks is much higher now than it was before in that circumstance. Good. Okay, well I think I'll leave it there. I'll close you out with the music that you guys like so much. And thanks again.